So this lecture is actually mainly in the clinical audience, and this I will just to Chatur's commenting when you are writing this guideline, EPTB and the latent TB guideline, we have several practical problems. Now, for example, giving to the latent TB to healthcare workers, so it's practically not possible Sri Lankan. So we have to have a lot of things to consider when you are writing that guideline to get a practical nature, same as to adhere to the world literature as well as a WHO. So sorry, that is everything. Another important, now I'm giving this TB lecture last 26 years I'm giving this TB lecture, even learn I got today from my own trainings. So this is ever-changing field, ever-changing field. Even this lecture was a little old one, prepared for some time before, but can be applied even today. So this is a subjects, respiratory medicine and the tuberculosis ever-changing. Even I learned from my own trainings and I listened to their few lectures. And actually so we have vast experience of the clinical areas on tuberculosis. What I'm going to tell you the little things and not much you are listening to from microbiology to every aspect of the tuberculosis. That's why we prepare the schedule today. I should know this microbacterium tuberculosis is a genus. It has many different microorganisms. But I want to tell you that most of these groups may be a typical microtubercular complex, atypical groups, and even within the atypical group, there are many subgroups. Most of these organisms and their clinical diseases share common clinical spectrum. That's what you have to know. Clinical spectrum. So even if the microtuberculosis or the avian, intercellular one, or the africanum, or even the microbial ulcerum, most of them share the common symptoms. So it's very, very important us to differentiate, is it tuberculous microbacteria or the tubercular complex or otherwise? Sometimes very difficult. It was a system where before we came actually after overseas training. Every lymph nodes of the neck was treated for mycobacterium tuberculosis, except and TB. Then there was a lot of non-responders, and all were treated as a treatment failure, and then started category 2 or 18. Then we told no, come. So then the atypical mycobacterium came into the scene when Niranjan was with me as my senior registrar. We published several papers on non-tuberculous mycobacteria. That was the first few papers in the Asia, and our had a very good recognition. The atypical mycobacteria never thought about those days. Never thought about those days. So that what was there 25 years before. Because this has to be a thing. These different groups share typical or almost same clinical spectrum. That's very important to understand. There are microbiology very important. Other important thing also over the today day from morning to now, what is important to understand the rapid diagnosis and the correct diagnosis. So you use for the microbiology, the histology to various biochemical and other investigation or genetic study for a definitive diagnosis, number one. Second, the rapid diagnosis. If you delay, there's more destruction, particularly CNS TB. I have seen 1,000 cases of what late diagnosis TB causing how bad the patient almost vegetative states. So the rapid diagnosis and early diagnosis as well as specific diagnosis must. And you talk about diagnosis, Chatur talked about the latent TB, the different aspects, and all other speakers on the parliament and talked about the active TB. We may use a microbiological investigation as a genetic. And that will be important, the epidemiological, like restrictive pattern polymorphism. We have done a lot of study with the IFS. We have published several papers on this. There are a lot of things. These are very important. The country is concerned. Our TB is not a unique. Our TB has a population like Chinese, Indian, American, like that. So we have a lot of new mutations. That information and knowledge is very, very essential. And we have classification, presumptive diagnosis, so-called TB suspect those days, and the bacteriological component and the clinical diagnosis. These are very important to know. When you bacteriologically come, fine, you are correct. But so-called presumptive diagnosis and the clinical diagnosis case, you have to be very vigilant. At the same time, you can't delay as well. So this new classification, these three names, you have to use optimally, try to come to the bacteriologically compound diagnosis, microbiologically or the genetically or by cultures. Very, very important. Microscopy was talking at the morning microbiology. It's a very simple test, very important. But taking 3 days in this difficult economic situation and practical different transport, is quite unacceptable. So same-day approach is very important. Because Damit was with me, we have published a good paper, how same-day approach is equally effective and equally significant, the 3-day approach. Because this is not possible in country like ours, we have a lot of practical and economic situation. And using the high LED technology. This is important. Just you have a positive smear acid pass bacilli. That don't think that it is only mycobacterium tuberculosis. No. There are many organisms. For example, all mycobacterium tuberculosis complex giver acid pass bacilli. The typical fellows are rods, atypical guys are curved. But remember that nocardia and Tuscumelia, Gordonia, and the Legionella, Scriptus, all are acid pass positive. Just because of someone having the lung cavity, having acid pass positive, may not necessarily be a mycobacterium TB, including histoplasma. How many cases of histoplasma we had it? How many cases of nocardia? How many cases of actinium? All acid pass positive, remember. Just because of acid pass positive, that is not meaning that it is a mycobacterium TB. This I'm already. So it's very important to think about. There are many other possibilities. Clinical picture and your clinical complete close observation of patient. Naturally, when you have acid pass positive, you are going to start ATT in the given case. Correct, you do it. But be vigilant. Remember that the immunosuppressed particularly, they have many other possible causes. Culture has no problem. The conventional or liquid or solid culture or the bacteria or whatever. If you're positive, good. That is the confirmation. Liquid culture is equally good, and rapid diagnosis of the liquid culture is very, very important for us to have early culture, not the solid, take us 8 weeks to come. And this PCR and LAMP and all the tests and pass and all help you us to come to genetic diet. That's very, very important. There are many talk on that, particularly gene expert line purpose is very important because we get a correct diagnosis using that. But unfortunately, we have a lot of practical problems. Same way, if you go for a histological sample, particularly extrapulmonary TB, where you can get a central necrosis. When I get a report of central necrosis from the surgeon sending to me, I may have to start anti-TB drugs. But remember, just because of the central cases necrosis, that's not necessarily be TB. That's again. So your syphilis, histoplasma, cryptococcidium, all will give a central necrosis. Again, when you have a caseating granuloma, yeah, TB is the number one, the commonest one out of all. But remember, if they are not improved, that is not going to be treatment failure. Think about, is it something else you are treating as a TB, as a caseated necrosis? That is what you are getting. So this is another important thing for you to understand. And the Dushantha has explained that neutrophilic. Early part of early serositis, it's anyway neutrophilic. But just don't think it's just a pyothorax coming as just patient presenting last 1 week. You probably for say neutrophilic, extrapulmonary pleural effusion, for example. As remember, it's a early part of TB, not necessarily bacteria. Same way when there's a lymphocytosis. When I was a registered and a junior doctor long years before, if a lymphocytic serositis, unless proof otherwise tuberculosis, nothing like that. It's nothing like that. For many conditions, the malignancies, lymphomas, and the sarcoidosis, even CABG and the what you call the Dressler syndrome, rheumatoid, all are lymphocytes. Just because someone has a lymphocytosis, don't think that it is TB. But you have other things has to be supported. Just don't go at one parameter. That's why the Esteban TB and Dushantha and the pulmonary TB Manil and all explain that. Now the important that Dushantha was talking about adenosine deaminase. He actually mentioned this, everything. Just because of adenosine deaminase is high, the lymphocytosis is more for TB, but remember that Dushantha also mentioned it. There are many other conditions, including sarcoidosis, can give a high ADA level. But at the given history, cutoff point and higher value, definitely supportive. IV, or day-to-day practice, we use it. But remember, we cannot take one investigation as the results to treat the patient. That's what I'm going to tell you. But there are many other causes can give a higher ADA level. Then our radiologist Lajit explaining you the different radiological innocent. Remember that none of the radiologists feature is a specific particular cavity or pleural effusion, nodule or miliary, anything you mentioned. There are another 100 causes for same radiologic appearance, but definitely supportive. Same way in investigation we carried out bronchoscopy and so on. Again, we get a biopsy sample, or again, those sample has to be used with the clinical sense. The problem of tuberculosis is overdiagnosis. Anyone coming in the high ESI and PUO, there's a tendency to start anti-TB drugs. Other biggest problem is underdiagnosis, where we were talking about the pediatric TB, underdiagnosed. Never think about the TB. I can give you the 1,000 story if I have time. Bony TB. I have seen patients 11 years before 25 years ago when I was a coronacal having a patient final report with the biopsy. The SYMPOSIUM is meant with the arthritis like feature, then there's erosion, repeated surgery done, but never thought about TB. When it comes to me, even half of the pelvis is gone, hip is gone, young lady. You never think about TB. Gone, totally gone, like a moth eaten. So underdiagnosis, another bigger problem is a late diagnosis and delay in diagnosis. That again, Aruna and the Peter together. In our several of our study, we have found what we call a lag period is more than 2 months when the patient has come to the doctor, MBBS qualified doctor. There was more than 2 months. They do lipid profile, but never do the chest X-ray. Patient comes to fever. Lipid profile and blood sugar, renal function. The delay diagnosis more than 2 months in this country. I published several papers on that. So these three are very important. What is so-called delay? I gave you some overall idea before I get into my topic. Dilemmas, according to Dixon, is a situation in which difficult choice has to be made between two different things you could do. Now, the pulmonary TB also we get a different. I told you now to give you some basic concept. ADO, like SMEO, culture, biopsy. If you have a positive pulmonary TB, for example, if a patient has a 2 to 6 weeks of anti-TB treatment and there's a black behind the improvement, that the ESR somewhat improved and the chest X-ray was slightly improved. So you are in trouble. Are you thinking of what else? You have to think about all criticals. That's why we are closely monitor the anti-TB patient. You can't keep like a diabetes 1 month treatment go and come to blood sugar, nothing like that. You have to closely observe positive or negative or pulmonary stratification very closely because we have a different aspect you have to think about. If someone has a poor improvement, starting with a simple thing like are they patient having the poor drugs, are they only standard doses or not a wrong dosaging, the patient has a poor compliance, are there drug interaction between the, we have seen the drug interaction between positive and negative interaction, and this is apart from mono or multi-drug resistant patient. Are there any local pathology having a bronchiectasis or ILD or COPD because delaying one or proximal obstruction? Many things are some. Or it's a dual pathology. You can have a TB with a atypical mycobacteria combination. TB with a lymphoma, TB with a malignant can be coexist. So that may be some delay. And the negative or clinical diagnosed patient, remember, we have to be very closely have to observe. These patients, you can just very frequent to observe. We have a very good paper from the Sark Journal, how the negative TB patients become. Every aspect of TB. The time is not allowing me to go detail. Usually 45 minutes lecture. Try to summarize 20 minutes. Every aspect, clinical, all comorbidities, every aspect of their social life, all has to be considered if someone has a negative improvement. So if you think there's nothing called dilemma there, if you don't know what to do. Because you are thinking only one side of the story, never as an open case. EPTB is very, very important as doing the nicely explain all these things. When any case of EPTB, think about the possible differential diagnosis. Have you microbiological prove on your diagnosis? That is what we want. Microbiology. It's a gene expert and specific this, not the SMEO. Culture is yes. Culture is a gold standard. There's no question that. Are you proven? If you're not proven, be careful. You are treating them, mucormycosis, aspergillosis, actinomycosis as a case of TB, like a joint, for example. Or you are talking the nocardia as a TB. Be careful. So you have to come to the microbiology. That's what I want to emphasize here. EPTB, there are different aspects. You may nicely explain it. So everything has to be considered, come to the specific diagnosis. Unilateral pruritus, again, doing the nice explain this. I don't have time to go to this. One patient I had, I think, one you were like around. This one had a diabetic and the CA, right renal CA, and the nephrectomy was done. The CKD patient on chemotherapy coming to us with a unilateral pleural effusion. What we found in the highly positive amount, very high ESR, and the exudative lymphocytic, LDH also high, ADO 34.55. Culture strain, we had to wait for some time. Gene expert was not done that time. This type of, this is not his extract, so this type of picture you're seeing the right upper zone changes, and there's a unilateral effusion. The nearest trachea central slight deviation. To do the ultrasound, again, you see the loculation and thick pleura. And now we have a luxury of having a CT also. You can look at the very specifically important feature. For example, this particular case, now this pointer. I can't see the pointer. Can you see this irregular pleura? Irregular pleura in that CT. That is the point. Now, for example, remember that medical student. There's a medical student. That's irregular pleura. Irregular pleura, the circumferential pleura, it is malignant, nothing else. It is malignant. So the medical student, what we had in the Peradi is irregular pleura circumference malignant. EAD high, manto is 18, unilateral CKD, no, it's malignant. So that is why go for invasive. This is some of my patients. By looking at the thoracoscopy, we know is it TB, is it malignant, or something else. So use this invasive. It is available with us. Available with us. All this nodule one, this is never going to be TB anyway. Acute time, you may get it before you get loculation, but before that, no. So use this one, come to the specific. Otherwise, you are giving the unilateral one and the TB. After those days, the patient has a malignancy. I can remember the 16-year-old young boy came to me from the Navalapitiya, about 20 or 22 years before. He had a lymphocytic X-ray. Those days, he was not there. Those days, it was X-ray 82. So he had osteosarcoma, giving secondaries. So use this thing, right? And think about all possible causes of unilateral diffusion, particularly lymphoma. So what I want to go for specific microbiological proof, if otherwise, get the definitive diagnosis. And genital TB is another very difficult situation to diagnose, very difficult. It's not that uncommon. A lot of young ladies come with infertility. So the infertility is a big problem. The TB, fallopian or uterus or the ovary or wherever. So difficult diagnosis. Then you have to go for very detailed assessment, the chest section with the laparoscopy, or even a support of our gynecologically, try to get a tissue and come to diagnose. Sometimes we have to treat as your ESR may be normal, CRP will be normal, MANT will be nothing. So it's not very difficult. So you have to have a very good clinical assessment going through each and every aspect. Joint and spinal TB, again, we have a lecture on spinal TB. Remember the several infections, not only TB, salmonellosis and the strep and the sickle cell with this one and the typhoid brucellosis, all give a similar picture. So that's why I always request microbiological proof. Unfortunately, I haven't got a single for last 28 years in my practice. So we have to use again, but then we go for a clinical chest X-ray, MANT, ESR, CRP, close loop survey. They can have multiple sites. We had enough cases like multiple where Dushantha was presenting his lecture is one of our publication. So joint TB, we like to have a pathological and microbiological proof, or less biological proof. Otherwise, we are treating some brucellosis as a case of TB. It's a totally wrong management. So there are many differential diagnoses for spinal TB. This has shown you several times. So we have a lot of publications. Joint TB, suspect different possibility. CNS TB, again, that Dushantha was addressing, it's not that easy. Several group of disorder, maybe infection like a plasma or the tuberculosis, brucellosis, all give a similar picture. Or necessarily like a sarcoidosis or malignancy and even a SLE, all give it. So diagnosis is not that easy. So that's why you have to use, for example, gene expert. Most important, when the gene expert not available in this country, we were clueless. Even not the AD was available. Now you all are with a lot of passage. When at the beginning, nothing was there. So we have to go for lymphocytosis and clinical pictures, etc. So many other things. So think about the differential diagnosis. And our college guideline EPTB, we are now going to publish it soon. Go through, we have given a lot of detail. And paradoxical reaction, don't go. When after you start anti-TB drugs for CNS TB, they worse at the beginning due to immunological reaction. Don't jump and say, no, it is not a TB. No, it is TB. It's a paradoxical reaction. It is applied for lymph nodes or CNS TB, any tuberculosis apply. So just because a patient worsening, don't think that it is something else. You have to know it's a TB. So all the aspects you have to think about it. And you cannot delay at the same time. They can go to permanent neurological damage. Same as skin TB. This is one of our patients. So this is actually atypical microbacteria. Skin TB, Again, I want the diagnostic group. For several on the basis of the carcinoma, leishmaniasis, and the TB, and so many other conditions can give us similar or atypical mycobacteria. So, being expert of that or Lyme prophecy and the culture mandatory meantime cannot deal like in a patient with economic scarring. So, what I'm trying to emphasize is get a definitive diagnosis. So then don't just emphasize to treat as a cases of TB. Pediatric we discuss in detail. I think who this our Aruna has had this leadership. Diagnosis is very difficult. Doing the bronchoscopy, gastric lavage, now the lamb is available easily. Those it was not available, still and stool and urine can be done and cannot delay the children. We discussed that part in that question time. I have experience how TB cases so delayed and how they manage. I have experience of so many number of years. Other thing is the TUO. Very common problem in the medical wards and pediatric wards. Among them the PUO, IS, ICRP, going on for some chest section normal, manto nothing negative, nothing dipo negative, ulcer abdominal negative, nothing. So tend to start a treatment for tuberculosis naturally. That's okay. If there's a but go into this particular case or referred to me by the Peradiniac. I think you all are around with me that those days. This is the typical like you're going to one of the police officer from Anuradhapura. And when I do with my SR, those 7 SR that time, doing the ward down, we are digging, we could not find anything. Then only thing what I found, then he tell that he had some animal contact in the police station in Anuradhapura. You all may remember this case, he published. So then I also checked immediately brucellosis serial. It was positive. It is doxycycline. Total therapy of 3 months those days. So the cases of brucellosis. Unless he missed that particular important component of the history, I could have started 80 because I have nothing else to do. So that's what this summarizing what I'm telling you. Miliary TB and dysentery TB again, just because of the miliary, don't think it's a TB. Could be, try to get like a bronchoscopy and ball and get a necessary specimen, microtransform biopsy, but not for all the cases. Patient miliary go for. But remember the all causes like a histoplasmosis, miliary, sarcoidosis, several conditions. Give us a similar picture. You have to think about it. But because time packed, I have to go quickly. I have to do all possible. It has to be think, history, examination, dig into the different area and try to get a confirmation. Don't then jump it just because someone has a miliary remodeling. That is not necessarily TB, but could be TB. Try to get support to what you have done. This is again. HIV and again I think this part just remember the HIV is a situation where they immunosuppress many conditions. Doesn't matter pulmonary or extrapulmonary can mimic TB. Like a malignancy, cytomegalovirus, or pneumocystis, or lymphomas, almost nearly same. That's one side of the story. Second side of the story, you may not get a positive single investigations. So then you may have to go for investigation like a biopsy and brushes and brushing and all this. Remember these different areas, very, very important. So TB mimicker is very important. So always TB has a mimicker. TB is a mimicker for many group of disorder. So that mimicker you need to know. That's why otherwise you are underdiagnosing the patient. So these are one of the mimickers, very, very important. I really like these group names. When we were registered, even saying that we never heard about those things. We had some postgraduate interest only. But later we found that these are there almost everywhere. We had to go for that. We had to go for that. Is it a knockout? They are there. So you have to go. Aspergillosis is one. We never thought about when we were registered. Now, how many cases aspergillosis? We have epidemic. We have epidemic. But we have to think, do a bronchoscopy, get a sample, and do a relevant testing. And this is something important. If you have a combination, like if you have a TB patient not TB, think about there's another disease should be coexist, like a malignancy or TB with ILD. Always think about the not the combination. Don't think only sputum only because it's sputum positive, man-12 positive, chest section typical, but not TB. No, nothing like that. There is another disease can coexist. That you have to dig and hunt and find out. That is why you are there. Not to give an anti-TB and just fill in the form in like in the TTCO in our no, that is not a clinical medicine. If you find any patient uncontrolled COPD or bronchial asthma, bronchitis, think TB can coexist with them. Treated, I have saved several patients' life by thinking TB and doing appropriate and giving the treatment, even as a trial basis. So this is finally, so TB is a good mimicker. So there's nothing called dilemma actually, unless you look for that. Detailed clinical examination mandated, not giving as it passed by the chest exam, nothing on the BST, never examine, never take history. Most of our doctors are so now lax. They are very reluctant to take a detailed history. No, totally wrong. Appropriate investigation must be done. They are available, refer to the appropriate people and correct people. Definitive microbial diagnosis is the most important. The most important. Otherwise, I'm always in doubt. Rapid and early diagnosis mandate, I told you the lag period. If 4 people are suffering, they are coming with a permanent damage, they are spreading the disease into the community. Therapeutic trial, you have to use whenever necessary. There is a 100% accepted, provided that you closely observe the patient. Dual pathology is there, most of the time there. And the paradoxical reaction, TB has to know, you have to know, don't think this is something else. I think that's enough for today. We will have question time. We'll answer. I just give you some overall idea, understand? So what you have heard, the so many aspects of the TB, this is just giving some clinical input to you all.